can see my slides now. Yes. In the next few minutes, I'm going to present the clinical neurophysiology, diagnostic procedures in patients with Alzheimer disease. As you all know, the diagnosis of the Alzheimer disease is based on clinical criteria. And to enhance this, we also use the biomarkers. And it's very easy to remember. So we have the ATN grouping or ATN classification, where A stands for amyloid, which we can measure it either from the CSF. We can do the amyloid with CT scan. We hope that in the near future we can also measure the biomarkers from the blood serum. And then the T stands for the phosphatase. Again, we have here the option that we do the CSF analysis, or we do the PET tau scan, but that's very expensive and it's not available in every center. Then the most easiest way to obtain is the N part. The N part is the neurodegeneration part, which can be seen as atrophy on the MRI. We can also analyze the tau component in the CSF, or we perform the FDG PET CT scan. And then we can, from the pattern of the metabolism of glucose, we can predict with certain certainty the neurodegeneration. What about P? Neurophysiological biomarkers. Are we already? Can we introduce P to our classification? So, from when we are talking about the neurophysiological biomarkers, I'm sure you're all aware that the most common way to assess the brain activity is electroencephalography, the EEG. EEG is with us for more than 100 years, and based on the EEG, we have also other techniques such as event-related potentials or event-related synchronization or desynchronization from the brain waves. So why should we use EEG? EEG has its advantages, but there's also some limitations. So first of all, it has the excellent time resolution. There are no better methods to assess that. We are talking about the milliseconds. However, with time it comes the poor spatial resolution, and the spatial resolution depends on the number of electrodes. It is also cheap. However, many times we require a secondary analysis. So what we can do with the EEG? First of all, patients can have their resting state EEG. What does this mean? That patients are lying still for 5 minutes with open eyes, and then for another 5 minutes with the closed eyes, or they can lie more. But what we need for the analysis is around 5 minutes. What kind of record we do? We use, this is the standard montage. The standard cap for which we use is like 19 to 25 electrodes, and this you will find in every neurological clinic or even in every department where they can do the EEG. But then when we come to the experimental methods, when we wish to increase our spatial resolution, then we are going up to 80 electrodes, or in some cases even to 128 or 256. But with beyond 80 electrodes, the spatial resolution is not improving so much. There's no linear improvement. What is actually the problem? Why we have to use so many electrodes? This is the reason because the brain is floating in the CSF. So, and when we have the source of the electric source, for example, if we have it on the occipital cortex, we cannot simply say because the activities in the it was recorded in the electrodes which are overlying the occipital cortex, like in this case, the O1 or O2, there should be the source. Unfortunately, there is the theoretical possibility that the current is floating around the brain, and it could be recorded in the frontal lobe, in the frontal electrodes. Therefore, we need more electrodes, and when we record from more electrodes, so we see the same event from different angles, we can see even the shift in the wave, with the shift in the source, and then we can say, yes, it is highly probable that the activity is in this part of the brain. Or we use different techniques, on which I will talk a bit more later. So what we are actually recording? We are recording 5 types of brain activity. So the most common brain activity, which is the most commonly written, which is in resting state, is the alpha rhythm. This goes between 8 and 12 hertz, which you can see here. But then when we start even with mild somatosensory or motor task or not very difficult cognitive load, this activity will change to the beta spectrum. So the frequency on which our brain is working is going to be higher, the amplitudes are going to be lower. And the beta spectrum is between 12 and 30 hertz, as you can see here, and more cognitive demanding task or more difficult task we have, the frequency will be higher. And then we can even go to the gamma spectrum, which is 30 hertz and above. But we have also the other possibility that if in the patients who are having some neurodegenerative disorders, or if they have some other disorders which affects brain, then those rhythms are going to collapse, and we are getting the delta and theta rhythm, which are very slow rhythms with high amplitudes. So the theta is between 4 and 7 hertz, and delta is between 1 and 4 hertz. Of course, in normal brain, all described rhythms can be present, but the ratio between them is much more in favor of the higher frequencies than in the lower frequencies. And this is already one of the solutions which we can have when we are recording patients with neurodegenerative diseases. I'm just giving you one example. So what can we actually expect here in EEG, in dementia, and in Alzheimer's disease? You see, when we are analyzing the EEG, for example, if we have a patient with epilepsy, it's enough that we analyze it by eyes. It's a visual inspection, and you need a trained neurologist or neurophysiologist who can read EEG. Usually it takes a few months to learn that and to get acquainted, and then several years to get practice, and more EEG you see, the better you are. But then when we are talking about the EEG in dementia, unfortunately, we need to use some other tools. It is not enough that we just say by visual inspection, oh, I think this is, there's more delta or theta written than in the case of alpha. And one of those tools is S-Loretta. This is the low resolution electrotomography. It is some mathematical process in the program where we can actually calculate and improve our source localization based on certain parameters, but it also depends on the number of electrodes. So in one of those studies, what they did, they actually compared the normal old, so the controls with Alzheimer's disease with red, and the Parkinson's disease in green, and the dementia with Lewy body in which is in pink. And what you can see is that in the posterior part or parietal part of the brain, the alpha spectrum is getting actually very low, and this is especially in case in patients with Alzheimer's disease. But then on the other hand, in occipital cortex, the delta frequency is getting more common. So this is the ratio between alpha and delta could be one of the surrogate markers. What is also important is that if you are reading the guidelines for diagnosing of dementia with Lewy body, you can already see that it's not under the main criteria, but it is under the surrogate markers. So the EEG is already in the guidelines for diagnosing the dementia of Lewy body as additional marker which we can use. So, but regardless that it is a bit difficult and we need more studies, there were last year, a year and a half ago, a recommendation on EEG in the diagnosis of Alzheimer dementia were published, and at the moment there is the resting state EEG cannot be used for standalone measures in daily clinic. However, it can be used, and it is proposed to be used as a stratification tool for 80 patients in clinical trials, because the reduced relative power density at alpha rhythms in posterior regions, like as parietal region, and increased posterior theta and delta rhythms could be a good surrogate marker. What is also we can do is that with the changes in the delta, theta, alpha, and gamma rhythms, those changes could be a secondary outcome, because we can actually see, we know, for example, that when we have the load of amyloid in the CSF, after a certain amount of time, regardless how cognitively impaired the patient is, the amyloid levels won't change very much. But the changes in the neurophysiological, brain rhythms, we can see that because with the progression of the dementia, the brain waves are getting more and more slow. So we are getting more delta and theta rhythm. What is also an interesting thought is that we could use those neurophysiological markers as a surrogate marker in the clinical trials to reduce our costs and to find patients faster. For example, we can use first clinical criteria to introduce patients to the clinical trial, then we can proceed with the resting state EEG. So we know there are changes which are indicating that patients can have Alzheimer's disease. And then we go further with expensive and troublesome biomarkers like CSF analysis or amyloid PET-CT or tau PET-CT. So we spend money more wisely, and we are reducing our load on on our resources. So this is the part. This was just a little bit of part on the resting state EEG, and I would just like to take a few minutes to talk about event-related potentials, because another way how we can analyze and how we can what changes we see in patients with Alzheimer's disease is that they also have changes in event-related potentials. Event-related potentials are potentials which we get when patient has presented a certain task. It could be the cognitive task, it could be the audio task, or it could be the visual task. So, for example, patient has to has an order that if he sees the letter A, he has to click the left button on the mouse, and if he or she sees the letter B, they have to click the right button. Or it's go no go. If they see a red spot, they should go. They should click the button. If there's any other color, they should not. So, and then we have we repeated this for 100 times, and then when we average the EEG signal, then we get our event-related potentials. What is very interesting is that there are early components, so whatever is beyond, from the time from the signal onset to the 150 milliseconds, and there are late component which is more than 150 milliseconds. And regardless what kind of stimulus we use, the early component is the same in all patients. We can use, for example, old ballpark, these working memory, executive functions, semantic function, and then we get different components, but whatever is beyond below 150 milliseconds, it will be normal. It will be the same. There won't be any significant differences between the cognitively unimpaired or patients with mild cognitive impairment or patients with Alzheimer's disease. Why is that so? Because this is the pure physiological response. There are no cognitive load in that one. However, the interesting part is when we come to the signals which are after 150 milliseconds, what we are interested in, there are components which are 200 milliseconds after the signal. So, and still those components could be, we say it's the N200 wave, but this means that on average it's around 200 milliseconds. It can be between 100 and 300 milliseconds. And then in patients with Alzheimer's disease, the amplitude will be lower and the latency would be longer. So this would be this is the most easiest to describe what we can expect from this one. I'm sure that you heard for the P300 component. This is the most studied wave. And again, we have the delayed latencies and we have the low amplitude. And however, those P300 we can get the best with some executive tasks. So patients have the go-no-go task. For example, 80% of signal is pink and 20% of signal is pong. And on every pong, the patient has to move arm or click the button. If there are more memory tasks or more language tasks, the P300 won't be the best to study. On the other hand, we have for semantic tasks, we have signals which are around 400 milliseconds. And again, there will be the lower amplitudes and the longer latencies. However, the sensitivity is not very well for the patients with mild cognitive impairment. You see there's around 70%. This is not ideal from the test. And also for the Alzheimer's disease, we can say, okay, 76% is okay. But still the biomarkers which we have is more than 80%. And then we have something, what it's called the perception of motions and motion onset visual stimulus. So patient has to localize and decide where the stimulus is going. And this is our sample when we are doing our clinical trial that it is sponsored by the National Grant Research Agency. At the moment, we are in the phase of the analysis, and it seems that the patient, we could use that signal also, those tests also for to distinguish patients with Alzheimer's disease from the cognitively unimpaired. To conclude, the neurophysiological biomarkers are low cost. They are reproducible. It's true that you need laboratory, but the laboratory is much smaller than one for studying the biomarkers. At the moment, there are recommendations to use them for recruitment in the clinical trials. However, there are more studies needed for their regular clinical practice. Thank you very much for your attention.
Thank you very much for your interesting presentation. I will ask you the first. How many expensive is the cost per patient age to be used in routine?
So, are you asking me how much this the device costs, or how much we are?
It is easy to be used in routine.
It's very easy to be used in routine, and you can. It depends on the country, but I think, for example, the one which we use for the experimental, that's really experimental. It costs around 40,000. But this is also with the caps with 64 electrodes. So if you're using for the clinical routine, I think it's around 20,000. But it still depends on the country. So,
is there any other question? Yes, please.
Okay, thank you. I was kind of late and I didn't hear the whole presentation. Sorry about that. From what I understood, by observing the EEG, you're trying to make some diagnosis. prognosis. Is it correct?
That's very simplified, yes. But this is, you cannot simply observe it as in the case of the patients with epilepsy. But we need to do the secondary analysis. We do need to analyze the frequencies, which are, for example, as I said before, the alpha rhythm, which is the basic rhythm, is decreased in the certain part of the brain, and the theta rhythm is increased. So the slow rhythms, there are more slow rhythms than fast rhythms in the brain.
Can you make the same? Can you reach the same result by observing the behavior of the person? I mean, do you need such an expensive device to reach such conclusion? Just use a very cheap camera, observe latency, observe the amplitude of reaction. You got it.
So why then we need the FDG PET-CT, which is even more expensive? Or if we are using the tau PET-CT, which is so tremendously expensive that we can't even afford to do it. We need, I understand what you propose, but unfortunately, I think that just the clinical observation is not enough to make a diagnosis of the Alzheimer's disease. We need some biomarkers. Yeah. I think there are also two ladies who were asking for the questions.
There is another question there. You have a question?
And there's the lady in the middle.
Hello, thank you very much for your presentation. I would like to ask you two questions. First of all, I have heard about the gamma rhythms before, but I don't know exactly, are they abnormal, or if they're normal, in what circumstances do we see them?
No, it's normal. It's a normal rhythm, but the more you think, the more cognitive demanding task you have, the more complex task it is, more your brain frequency is higher.
Okay.
And then more gamma rhythm you get.
Okay, and one more question about the N400 and then
Yes.
200. We say that the lower amplitude, you mean more negative, or?
No, the amplitude is simpler, is smaller.
Okay.
The amplitude is smaller.
Okay,
Yeah.
thank you.
Yeah. And there's another lady.
Thank you very much for nice presentation. I am also doing MAG on my patients, Alzheimer and dementia. I assume I probably missed, but I was going to ask you about exclusion criteria for your research.
Oh yeah, it's I went very quickly. The first exclusion criteria is the CDR. So that first the patient has to have the Alzheimer's disease according to the guidelines. But then the second one is that the CDR. We are searching for the patients with the CDR score, so clinical dementia rating score, which is 1 or less, which is also the CDR are mostly used in the clinical trials for the mild cognitive impairment and mild Alzheimer's disease. And then there are also the other standard exclusion criteria, like some vascular lesions, etc.
Probably you also don't get participants like late stage Alzheimer, right?
You see, the problem with there's another limitation of we can do the resting state EEG because the patient
they are vulnerable and
they're lying, but the limitation of the event-related potentials for patients is that we can't get their cooperation. You know, they have to repeat 100 times one task, and this is very hard for them.
Thank you.
Another question there. Okay.
I think we'll run out of time.
A brief one. So thank
Yeah.
you for the presentation. So my question is, do you think that the EEG could be a marker useful to define those Alzheimer's disease that have combined DLB disease? So in terms of define the component that
I understood your question.
Yeah.
Yes. Thank you very much. It's a very good question. There are two parts of the answer to your question. So first one, I'm not really aware that anyone did any clinical trial in that sense. So there are no data to support what I'm going to say next. This is just my thoughts. Is that yes, probably there could be the difference, because we know that the patients with the DLB, they can also have a bit lower amyloid, but we really need the clinical trial to, at least a small trial, to see what if this could happen. Thank you very much.